Barney. She's familiarly known about 14 years ago, one of our main fellows here with us at anesthesia consultancy training in Britain. Went back to a very neat job from which I could not manage as lead. Since then has been part of things like developing neuropathic pain guidelines as well as a lot of work in neuromodulation for treatment of neck and chronic neuropathic pain. So we have been very pleased that he was able to come and join us this year, spend a couple of days chatting with people, meeting with people, and he's going to present today on his work with treatment of low back pain, particularly neuromodulation. So Barney, welcome. Thanks very much.
Thank you. Apologies for the people who are watching through the distance. I might just keep walking. That's my habit of doing my lecture. So if I do walk away, apologies. Right. I think it's got about an hour, and my plan is to try and look at what I can do in this one. When I sent the program, Joe basically said, "Oh, you can't do neuromodulation again. You've only done it recently." So I thought I'd go back and check the recent program. Just had a link to that. I couldn't find any neuromodulation in the last 2 years, so obviously Joe here. These are my disclosures, and I do have an advisory role with quite a few neuromodulation industry, and I also get research grants from companies which is independent grants. They offer you the grants, but they don't interfere with the work. There are some studies which are run based on the research grants from the industry. So in the next 30 to 40 minutes, it all depends. I'm very bad when I stand in front. I can just keep talking. So I'm going to try and keep up the time within 30 to 40 minutes. Talk a little bit about our service and what we do, and how I was involved in some of the back pain research, and also with some of the new research which has come through in spinal intervention, which has a few hits in Europe on how it is remunerated, and just touch a little bit about other research work that we currently do in Leeds and in Hong. So for those of you who are familiar with England, Leeds is just a city north from London. It's about 200 or 108 miles north of London, about 30, 40 miles east of Manchester. It's the third largest city in the UK, even though the names like Manchester seem to be well known. But as a city, the population of Leeds is higher than the city of Manchester. 770,000 population. And we actually take a research sector for the whole of Yorkshire, which is about 5.4 million population. And our hospital budget is approximately for a kind of look. We have approximately 180 anesthesiology consultants. On top of that, we have about 140 trainees. And that's the size of the unit. We have something like 38 operating rooms. This is our team. Even though it's a big hospital, our team is tiny. We have 4 consultants who all have 1 day a week or 1 day every other week doing anesthesia, and the rest of the time we do chronic pain. We have some clinical psychology time, specialist nurses whose predominant job is neuromodulation. The volume of work that we do, taking in, looking at it, because you've got to check the devices, you've got to make sure that the activity is run out, you've got to optimize the therapy again. So they tend to spend nearly 90% of the time simulation and we have 3 full-time research nurses who again are predominantly involved just in research. They don't do any clinical work. We have one physiotherapist, and we have functional neurosurgeons in the public who joined us about 4 years. And his role is sort of asset that helps us the rest of the time is predominantly. So why is this such a small team? Because the city of Leeds is quite a big city, but the way they structure the paying services is they have contracts with private providers to provide, or one private provider and one health provider to provide paying services within the community. So there's approximately about 80 different areas where they run small paying services within local services, so the patients can drop in. Most of that service is based on cognitive behavioral therapy and rehabilitation models with some pharmacological manipulation. And they have an access to our services and purely when they want to offer any spinal intervention as a part of the rehabilitation. So it's not on its own as a therapy, it's part of the rehabilitation. The other thing we offer is cancer service. We have the biggest cancer hospital. We have dedicated 4 sessions a week just for cancer pain, of which 2 of them are MDT, the palliative care, and the other 2 are clinical and for cancer pain. We have opioid reduction clinic, as we all know, opioid is a problem, and we have the same in the UK, but not like that. But we do have a clinic which is run on 4 basis by a psychologist and counselor. And we are also part of multiple entities. So, just to give you a background of how the health system works in the United States. So, NICE is National Institute for Health and Clinical Excellence. This is a body which actually decides the treatment is good. So, the NICE evaluates every therapy which comes in based on the available evidence, what kind of quality of life improvement you get, and what's the cost saving for the NHS. Based on this, they either recommend or they say don't use this therapy because it's not worth money for treatment. So they evaluated spinal cord stimulation in 2008, and the report was to say this is cost effective, and they calculated based on quality of life per year, and that's based on the amount that you incur per patient. So if you look at this as a kind of a graph, where you have one side you have least effective but least cost as per the NHS, then they really don't want to know about it. If it doesn't work, you're not interested. You have a therapy which works really well, but it's really expensive. Then they look at the cost attached to it and see whether this is effective. And the other extreme, you have something which is very expensive but doesn't work, that gets out. Very cheap but really works well is recommended straight away. Spinal cord stimulation goes on the expensive device, but it's worth spending that money. So that threshold in the UK is £20,000, and the spinal cord stimulation falls way below that at the moment, around 14 or 14,500. And so the NICE has actually recommended to say this is a cost-effective therapy, and it should be offered as an essential service in the NHS. And that helps clinicians because then you can actually commission a service and you can run a service to really develop around that. And that's the quality. So quality of life per year, yeah. So in Leeds, they were doing approximately about 10 to 12 implants in 2006-07, and approximately 13 intrathecal pumps, which is a combination of both non-cancer and cancer pumps along with baclofen. We currently have approximately 59 patients with intrathecal pump, but this is predominantly baclofen and cancer patients. And we have patients, cancer patients, we do about 10 a year, but they come and go. Every year is just variable. But all funding for non-cancer intrathecal pumps has been pulled out. And that's purely because there's no evidence to support the use. And we have to apply for individual funding requests for each patient. And the chances of getting that approved is near enough to zero. So you're just wasting your time. So we tend to focus just on baclofen for intrathecal pump with spasticity and cancer pumps for patients. And our neuromodulation numbers have grown exponentially in these years. So how do we run the service? We get referrals either as a tertiary referral, specifically coming through from hospitals to say, can you consider neuromodulation? And also we have referrals within our services in the hospital from other specialties sending across patients for neuromodulation. They are assessed by the consultant right at the first appointment. They then sent across to our specialist nurses where they spend approximately an hour, which is an information session run, showing the kit and talking through the pros and cons and what to do and what not to do and so on and so forth. They then get to see psychologists if their expectations are too high. They tend to see the pharmacist if they're on high-dose opioids. And they tend to see the physiotherapist if they have fear avoidance behavior. So we have to work with all of those, and then they come to an MDP meeting for discussion before they're placed on the list. Whereas there are some patients who are straightforward, who have a definitive neuropathic pain, realistic expectations, not on huge opioids, they go directly to list. And we either do a trial or a full implant based on the patient's indications. If they fail, they come back to us and we do further management away from interventions. If they carry on, then we tend to look after them within the neuromodulation service, where they are followed up about 7 to 10 days for wound check by the family practitioners most of the time, or if they live close by us. And then we see them at 6 weeks, 3 months, 6 months, and then every year we follow them out. So this means we are slowly increasing the amount of patients that we are actually accumulating within the system. So we're now trying to introduce kind of tele-monitoring and kind of tele-follow-ups and paper-based follow-ups to try and reduce that workload so we're not inundated with follow-ups, which then stops you from actually offering this to the new patients. So June 2017, time of referral to doing a full implantation was approximately 99 weeks. We then dropped it down to 66 weeks, and now we managed to come down to 23 weeks. And this is all from kind of changing the pathways, making sure the patients are not wasting too much time waiting for these particular therapy areas. And we are expected to come down to 18 weeks, and that's what we're working towards. Because NHS works on the target of time to treatment has to be less than 18 weeks. So does it work? And I think for some reason the slide is just gone. Right, okay. Let's take a photo. Never mind. No, it's just in the same slide. This picture has actually come on top of it. It's supposed to come after the ones in the behind. Doesn't seem to work, doesn't matter. I think the animation's gone. Just to show you, we looked at the data on about 220 patients retrospectively. And this is this ongoing collection. So we got some medical students collecting further data. We are currently around 450 patients' data have been collected, looking at how they've done and what are the complications. And that's the bit which is actually being hidden behind. So in essence, what we found was we are actually making a big difference in the quality of life. And the quality of life is designed by the far end, which is the EQ5D, which looks at the quality of life change. And we've constantly showed that there is a 0.2 increase in the quality of life. Whereas when you look at the pain scores, we have 2 points drop in the pain score, but it does not really correlate to what the patient tells on the notes. And the reason behind is the patients have become a lot more active, back to work, and all those things can't be captured in your VA score. Whereas that is well captured on your EQ5D. So we've now moved on for a national level. We wanted to set something up. So we've set up a national database, which is collecting all the data around the whole of UK. I currently chair this group, and we developed this probably over the last 2 years. And it was launched in March 2018. The idea is every single hospital which does neuromodulation has to enter the data. It's in its infancy at the moment, but the government has insisted in every single document that they produce to say this is going to become mandatory for anybody who is doing neuromodulation in the United Kingdom. So they've launched a new product called Get It Right First Time, which is predominantly making sure that the patients are not being shopped around in different places and to just get the right treatment at the right time. And they've actually recommended that neuromodulation registry is a must, and also they have put that in the specialized commissioning as a service performance indicator for the service. So in essence, if you input all 100% of your patients, then your team gets more credited for what you've done. Currently, this is October 2018, so it was 6 months down the line we looked at the data. We had about 600 entries at that time, and this is a third-party follow-up. The patient gets an email from the team, the central organizing audit team, and the patient fills it online. So there's no direct clinical involvement in collecting this data, so there's no bias from collecting the data. You can see that majority of the systems that we currently have is spinal cord stimulation in this particular database. And these are the number of hospitals that were currently, or at that point in October, taking part, but this number has grown now. We have 19 hospitals currently inputting data, and we got more than 2,000 data entry points, which we are looking at trying to analyze at the end of March, which gives you 1 year data. Just this interim analysis showed that the majority of the cases in the UK that we're performing were for failed back surgery syndrome, which is what you would expect anywhere you go for spinal column stimulation. And the other things that we do are complex renal pain syndromes, post-surgical pain, visceral pain, migraine, so those are smaller proportions. And when you look at this data, you can actually see that the number 5, 6, 7 is the patients who have improved, much improved or better based on the patient's global impression of change. And this is quite a powerful tool to actually try and get your payers to say, look, this is what we're making a difference to your patient, you need to fund this. And that's key for us to collect this data. And the other data we collect is the quality of life, which is again a key data. And we show that there is approximately 0.4 increase with peripheral nerve stimulation and nearly 0.3 increase with spinal cord stimulation. I don't think you'd see this kind of change in any other treatments that you're currently offering on a long-term basis. But this is also a key data for us to try and keep the service going in the UK and also to expand it as time goes on. So what are the other driving factors which makes this kind of more interesting for us? The NICE looked at back pain, and in 2012 they published the first guidelines on NICE back pain guidance, and that clearly said no injections. They completely said none of the injections can be done. If you have a problem, you get manipulation therapy, acupuncture, and then spinal fusion. So they just completely did a guidelines which was very badly done at that time, and it backfired in big style, so they had to redo the guidance. So they redid the guidance, and not much changed. So in essence, most of the non-surgical options were still included except acupuncture, because acupuncture was not funded anymore in the NHS. From the spinal injection point of view, there was a huge change. All repeat injections are thrown out because you cannot offer repeat injections for anybody with spinal problem. You can offer medial branch block as a diagnostic tool, and when you do that, you need to show that the diagnostic tool is positive before you could offer one radiofrequency treatment. And the radiofrequency can be repeated as long as it's more than 12 months between the treatment. And the cost effectiveness data in NICE guidelines shows it's 19 months if you have to do a repeat radiofrequency, but still they agree to do it in 12 months in local hospitals as you do in contracting. So the whole dynamics change. So even epidural steroid injection spinal stenosis is not allowed because there's no evidence to support its use. So all of a sudden, from doing a lot of injections, people had nothing else to do because it was all defunded. So we had a flurry of referrals for spinal cord stimulation at that point. And when you looked at them, they were all actually appropriate patients who could have done well with neuromodulation, but it took way too long for them to come to us. But that's another increase in the number of patients that we saw once this NICE guidance was published last year. You can do acute epidurals or nerve root blocks for disc prolapse-related symptoms, but it's not something that you can constantly give every 3 or 4 months, because that's not allowed. You're allowed to give it for acute episode, and that's it. It stops there, and you have to find a definitive treatment after that, or they have to be in the community for rehabilitation. So it's very new. We started doing this only towards the end of last year, and I don't think our practice has changed hugely, because Leeds always did that for the last 7 or 8 years. So our practice has not really seen any huge changes, but it has changed a lot of pain practices from what they used to do to kind of adopt to the new ways of working. Surgery, if it's back pain, surgery is completely no-no. So they've just basically said no fusion surgery for predominant back pain. And that, again, is something that the spinal surgeons practice in our hospital anyway, so we never used to do spinal fusions for pure back pain. They have to have radicular pain if they're going to have back surgery. And all this is done last year, and then we got this recent publication. I don't know how many of you read this paper on passive joint radiofrequency done by the Dutch team. Anyone seen this paper? Right, yeah. So what do you think about this study? Everything was negative, wasn't it? Yeah. So do you think the study was well conducted right? So this is a MINT study which was looking at passive joints and SI joint radiofrequency treatments. And one thing that they did not have a control was how to control the treatment. So in essence, everybody were allowed to do how they wish to do the radiofrequency denervation. Most of them used the perpendicular technique rather than the parallel technique. They all had different gauge needles of anywhere between 22 gauge to 16 gauge. And some of the X-ray shows that the needles were nowhere close to the nerve. So in essence, the study was predominantly placebo versus placebo, which I think had a big impact, because the Dutch government has now completely stopped every spinal injection, including radiofrequencies. And this is going to percolate very quick into Europe, because all the healthcare industry is quite interested in saving money on things like this. So the moment they see the MINT trial being in the main area, it will be very quickly picked up. So I quickly looked at some of our local hospitals. So we are only 4 of us, and we are all very focused on how we do our treatment. So I did a little retrospective audit of looking at X-rays to see how well my colleagues were doing. And it was a bit shocking, and we had a little educational session, and we're going to try and re-audit. So within our own team, we realized, even though we are a tertiary services, there was huge discrepancy in how people did the procedure. And that's going to be biggest hit for us when it comes to passive joints, because there is no uniformity in how it's done. Or not just the uniformity, just the understanding of the placement of needle and the position in that you want to be close to it. So this is just a little example, as you can see here. You can see that the L4 medial branch there is definitely looking bad. It's just way superior than where it needs to be, right? So you do a inferior oblique view, you can see not just that, even the L3 is probably away. And the reason behind it, you got the mammuloaxillary ligament, and you've got to be through the ligament to get to the nerve. If you're out of that ligament, the local is not going to reach to that nerve. That means that level is not being blocked. So that can have an implication on how the patient's outcome is going to be on the diagnostic block. And again, this is another one which looks really good when you look at it straight on. And all you do is do an inferior oblique view and see where the needle tip is, and you can see the L4 is not anywhere close to the target. And if you just went with just this picture, you're quite happy. It's pretty much decent block. But when you go in detail looking at the views, you can actually, and I didn't want to bore you guys because I've also got plenty of images on when people do radio frequencies where you know the needle is nowhere close to the nerve. Some of them use 5 millimeter, 22 gauge needle. You might as well not do radio frequency because the lesion that you're going to create is so small. So we generally recommend you want to be using 18 gauge, 1 centimeter active tip as parallel as possible. And this is what's killing us, because people who are academically interested and want to do studies are not interventionists. And when they do the studies, they just do not control this. And when you don't control this, the outcome you're going to get is, I mean, the possibilities are even if you do control well, you could get a result which is negative for us, and that means it's a nail in the coffin for passive joint injections. In the UK, there has been a big call for a study, and we have put in a bid for the study. And there's quite a few people interested. And when I look at the rest of the groups, there are groups who are academically very strong, but they don't do interventions. So if they carry out the study, we're back to square one. And yeah, I don't know what it is like in Canada, and this is something that I found. We've been running a course for the last 12 years on how to do spinal interventions, and we've even written a book about it. But it's still not, people who perform it, they always think, yes, my way always works, and until you actually see a film with somebody else, then you realize, oh, right, okay, I've been doing it wrong for the last 15 years, and you try to change after that, or maybe not. Anyway, so now moving on from there, so this is only what we can do as an intervention in our service. So that means predominantly our practice is always been neuromodulation, and we still predominantly neuromodulation with just a service as a middle branch block for diagnosis. If it's negative, they go back to the community. If it is positive, we offer them radiofrequency and they go back to the community. And even that, they post a questionnaire back. So they get a questionnaire where they mark the amount of pain relief that they get for the first 6 hours, and then the following day, and then they post it. And if they get 80% plus response to the medial branch block, we offer them. We debated about 2 blocks, but in the health economic model of NHS, it's probably not going to be useful for us to 2 blocks. We debated about a single block, but then the amount of the referrals that we get through are huge. And when we do this diagnostic block, we realize we only get through about 30 to 40% of people for radiofrequency generation. So that's a huge amount of work that we can avoid doing if we can. So my interest was in patients who've never had a back pain. So there are a huge cohort of patients who have no surgery for back pain, but still come and go into the hospitals. And you probably see them in your clinic. You examine them and you touch them and you go, and they're normally very young patients whose life is completely changed. They used to be very active. They had a simple injury when they're playing football or something in their life. And then it becomes a vicious cycle. They lose their job. They lose their family life. They're dependent on government funding to do their day-to-day activities. And those are patients where there's no surgical pathology of MRI scan, so the surgeons are not interested. And it's a big cohort of patients that you would probably remember. And again, when you do injections for them, when you try to put a needle through, they feel every single bit of it. You cannot sedate them that easily. And if you do give a lot of local anesthetic, they are not very comfortable on the table. And I'm sure you all have seen that patient and you think he's probably bonkers. And I don't know why I'm doing this, but I'm still going to do a block on him. And I think that's the kind of patients we looked at and said, right, can this be central sensitization causing neuropathic pain? And those patients should do well with neuromodulation. And these are young patients. I'm talking about in their 30s and 40s. So the first study was done by Dr. L. Casey in Guy's and Thomas's, where he did a cohort of 20 patients looking at who've never done or never had a back pain, back surgery before. So he called it a virgin back study. So these patients, at this point when he selected the patient, he did not actually look into anything in detail about neuropathic pain. All he did was he had this generalized exclusion criteria which we always use for neuromodulation, such as alcohol, no opioids, sensible patients, and the term that he used is, if this patient is fit enough to be my neighbor, I'll implant him. And that is kind of, I call it a gut feeling, and I think it's a very, very nice way of selecting the patient. But it's not something that anybody else can do. He can do it, but you can't replicate it. You cannot actually go out and get another doc to do a similar kind of selection because it's not easy to get that experience to do that. So he started off, as you can see, sorry about the slide, it's quite small. He started off with 98 subjects who were screened, and only 21 got enrolled into the study, of which for 20 patients he has got 12-month follow-up, and for about 17 patients he's got 3-year follow-up. So this is a fairly long-term follow-up study with this group of patients who have no surgical pathology, predominant back pain. So as you can see, the baseline, they're all young, 40 plus, 30 to 40, fairly disabled with pain with a PAS score about 80 to 90, and office street disability showing about 53 to 63 out of 100, and quality of life is way poor because normal quality of life is 1, and in the UK the quality of life, we call it is 0.89 is actually considered to be a good quality of life, and 0.17, as you go closer to 0, you're good enough being dead, and if you're minus, then you're definitely dead, and that's what it means in simple terms. And if you look at the time of onset, these patients have had pain for fairly long periods, anywhere between 7 to 12 years. And these are the patients who have had facet joint injections and epidurals and various interventions done to them over this period of time. So these are the changes on the MRI scan, and I think MRI scans are particularly useless in this group of people because if you do MRI scan, you're going to find changes. And it's not something which is really useful unless otherwise there is an obvious pathology which is surgically amenable. And in essence, you have to have a signs and symptoms which correlate to the scans. And we don't generally find these in this group of patients. So the technique is very simple. 2 epidural electrodes covering T8, 9, 10, 11, and majority of the time the sweet spot is in the T9, T10 disc. And this was using a 10 kilohertz system, which means the stimulation parameters are 10,000 hertz frequency with a pulse width of about 0.3 microseconds and an amplitude which ranges anywhere between 1 milliampere to 3 milliamperes depending upon the patient's perception. And these are the results. You can see there's a significant drop in the pain and the ODI scores, and this is consistently maintained for 36 months. And this to me is quite a good result. But the only thing I couldn't get out of this when I saw the first result, which is at 6 months, is how do you select the patients? Because there's no definitive answer for me to say how we selected the patients. So they also used the pain detect questionnaire. And the pain detect questionnaire was interesting because they had a group of patients who showed neuropathic, a group of patients who were nociceptive, and a group of patients who were mixed. And outcomes were exactly the same in each group. In fact, there was one patient who failed was on the neuropathic group after the pain detect. So the questionnaires that have been developed currently for other conditions might not be transferable to your back pain because they're not validated for back pain. I think pain detect has got some work done on back pain, but most of the other things such as your LANS and SLANs and DN4, they're not validated for back pain. The responder rate is nearly 80 to 90% throughout this 3-year period, which again is fairly good. And the opioid reduction, as you can see, these patients have significantly reduced their opioids since they went on. And most of them actually, some of them actually went back to full-time work. And that's a good success because once it's not just about getting the pain relief, getting them more active and getting them back. So if you look at this graph, you can always see there is always a drop at about 3 months. And then there is an increase. And that's purely because they are quite sedentary until at that point. And at that 3-month point, they realize, okay, I'm okay now. I'm not as suffering as before. So they start being more active. And the pain scores generally tends to go up. And that's something that we tend to see with most of the interventional studies. You drop down, and then once your activity goes up, there is a slight increase in pain after that point. And then it becomes more stable. So I put forward this study, and I called it a maiden back study, because I have to have a different name. I can't have what Adnan has. So I called it a maiden back study. And the only thing that I did different is to define my patient selection. And I defined my patient selection right at the beginning, saying I want all of them to have an SLAM score less than 12, pain detect score to be 19. So in essence, I wanted them all to have a neuropathic predominant pain, so I could show that this is neuropathic pain. Exclusions were similar. You don't need to be obese. You shouldn't be on too many medications. No other extra bits and pieces like pregnancy, cardiac pacemakers. This is very, very kind of routine for any neuromodulation studies. So we started recruiting. I just went through to the first few cases which were okay. And then continuously there were 3 patients who failed my screening because I look at them, I clinically examine them, I 100% think that there is neuropathic pain, and they fill the questionnaire, it comes back as nociceptive. So I stopped the study and I went straight to Mike. Mike Bennett is the guy who developed the lead assessment for neuropathic signs and symptoms, and he happens to work very close with us and he just lives around the corner from us. So I went to Mike and said, Mike, this is rubbish, your questionnaire is not working because I've examined the patients, they have allodynia, hyperalgesia, but your question doesn't show that. And he said, no. 2 things. 1, the questionnaire was validated with you guys, so you're the gold standard, and the questionnaire was devised for community team who do not understand what neuropathic pain to be able to pick this up, and that's where the whole questionnaire was developed. This was not developed for people like yourself who are experts in this field. And number 2, it has never been tested on back pain. Some of the questions where you say, does your skin color change blue, red? They can't look at their back. So this question is just completely useless. So I then went to the ethics board to say, right, I'm going to change this inclusion criteria. I want to put clinical allodynia and hyperalgesia as my selection criteria. Guess what? They dragged and dragged and dragged. They said, you're doing this so that you can increase your accrual. I said, no, this is the fact. Look, I've done all these work, and the questionnaire was developed by Mike, and I've had a chat with him. I said, oh, no, I think you're doing this because you want to. So they gave us a bit of hard time before they approved us, and eventually we got moving. And once we started doing that, I think our selection became very clear. As long as the patient has got hypoaesthesia, allodynia, or hyperalgesia in their back for skin prick and cold and cotton wool, they were included in the study. We collected quite a lot of data. The reason why we wanted this is we did not want just outcome data. We also wanted to calculate the health economic data. So we collected things such as analgesic requirements, how much concomitant medications, such as your anti-neuropathic drugs that they're using, what was their employment status, and also looking at the data, looking at how much time it takes, what is the cost of the implant, how long they stay in the hospital, and after that we also collected the number of visits to the GP, whether it changes. We collected the one before and we collected after to compare them to see whether we've actually reduced the attendance to the GP practices. From the outcome point of view, we collected the ODI VAS similar to the last study, PGIC, and CGIC, which is the clinician global impression of change. And all these patients are implanted again the same HF10 system. In this, I added another questionnaire, and I call it a lead back pain questionnaire. We have to still validate it, but what we wanted to find out was put the pain characteristic in and say, right, okay, if somebody has a pain on extension, lateral flexion, or rotation towards the ipsilateral side, the chances are it has got a predominant nociceptive mechanism, and vice versa. So I've put down all these questionnaires, and at the moment the plan is to try and compare the outcome to these independent questionnaires to see if there's any correlations of predicting if a patient has certain history and examination, they might be suitable for neuromodulation. So it's a work in progress, but hopefully the next study that we've set up, which is a multi-center European study, we will hopefully be able to get some answer to it. So these are the data that I've collected. Our patients, again, they're quite young. I haven't got the dates here. They're approximately 40 to 50 age group. We have our 20th patient has just crossed 1 year on the 19th of January. So it's recent. And so I haven't done the full statistical analysis on all the data we have. I've just done a very small amount for this meeting. And I'm hoping to write this up in the next few months. And we showed a similar reduction. So in essence, it's the same kind of outcome similar to what they saw in Virgin Back study, except that we are able to say the selection criteria was very clear. So anybody can now select the patient. So if you clinically examine somebody and you have allodynia hyperalgesia, there is no surgical pathology present, then they are suitable candidates for neuromodulation. And that was my first patient, who happens to be a medical physics guy in our own hospital, who generally tends to come to work, spend all day at work, and then he goes to the couch. And that was his life. And he sent this picture to us to say, I thought I'd like to show you the effect that your recent reprogramming has had. He's become completely active. He's got back onto his motorbike, and he's crossed 4 years now, and he's still doing really well. And I know that because he lives in the same hospital, and I see him in the canteen every now and then. So our results are very much comparable, and I think if we do combine this group of patients, you can say all the 40 patients have got exactly the same results, except that we are able to pinpoint the selection criteria. So we're doing a randomized control study comparing this with a conservative management, a multi-European site study looking at 150 patients to be randomized. I think we've randomized approximately 44 at the moment, so we're still a long way, but I'm sure we will finish the study soon. And this is looking at CMM for 6 months comparing to HF10, and then they're allowed to cross over to the active treatment arm. And then we're going to look at the results at 1 year and 2 years. So we're talking about neuropathic pain, and I thought this would be a nice thing to really, because I have a lot of interest in research, and it's very much device-related research, and I wanted to share my experience with this company, which came to me in 2012, and how the whole therapy evolved, and what made it quite interesting for clinicians to really be a part of research, but still enjoy your research, and this is one of the examples of that. So this company came to us in 2012 with the idea of multifidus muscle being a predominant pain generator, and whether we could stimulate the multifidus muscles 20 minutes in the morning and 20 minutes in the evening to achieve mechanical stabilization and pain relief. And this was their question. So the theory is multifidus muscle is the mainstay to your back, and there's a group of patients who get injury, and after injury they cannot rehabilitate because the muscle does not have the neural drive to get better. So if you're a normal person who gets injury, you go and do physiotherapy, you build your core strength, and you move on. Whereas this group of patients don't. They typically live around their back pain. They just say, oh yeah, I've got to be careful. I can't do this. I can't bend down because my back goes. And when the back goes, they're out of work for a couple of days. They take some diazepam, ibuprofen, and then they're back to routine. And they live their life very carefully. And I'm sure you would have seen those kind of patients who you've seen in your clinics. And we looked at that as the group of patients to say, right, why are they not getting better? That's because they're not having the neural drive to increase. So we started looking at MRI scans, and in MRI scans you can actually see the multifidus muscle completely atrophied on one side, and you can also see a lot of fat infiltration in really young group of patients. So you would expect, why do you have so much fat into the multifidus muscle? So we kind of selected these patients, and we went through quite a lot of physiological measurements looking at putting the multifidus muscles into contraction, and then selecting the patients for the study. So the first was a feasibility study. So the theory is you have an active injury, your muscle control goes off, and then you got functional instability, overloaded joints and tissue, and then you go into a vicious cycle. So the idea is to try and change that and reactivate your muscles, get functional stability, and reduce your pain. And that was the theory. So the company came to us with this idea, so we had to do the study. The study was purely a feasibility study looking at trying to see, can we actually, does it really make sense to say that this will work? So we started the feasibility study. We found out that the feasibility was positive. We then moved on to develop specific kit to do for this particular study, and then did an FDA study. So we were a part of the whole pathway for the company throughout the procedure. So when we first did, you all probably know how we do radiofrequency denervation or anywhere close to it, and it's exactly the same. So we place the needle to cover the L2 medial branch block. And the L2 medial branch block is purely because they did a lot of anatomical studies looking at the multifidus in 3 different layers. And if you stimulate at L2, you tend to get the whole group of muscles. So those of you who do motor stimulation, how many of you do motor stimulation for RF? How many of you see the contractions? So when you see the contraction, you get excited because that's what you're looking for, right? And next time when you notice, try and see where you get the most contraction. It's normally at the L2 medial branch. And as you go further down, it tends to be less and less because it tends to have less effects on the superficial ones. So we place the electrodes, off-the-shelf electrodes, onto the L2 medial branch, like a lateral approach as we would normally do, and we tested it. And it was a disaster. It worked. The pain relief was amazing. 20 minutes in the morning, 20 minutes in the evening, they just ramp it up. The muscle goes into contraction and then slow relaxation, fast contraction, slow relaxation. The patients loved it. But the electrodes were just pinging out like anything because obviously when the muscle contracts, there's nothing to hold the electrode. The whole electrode was being thrown out. So we then moved from lateral to kind of more medial. But eventually what we found out was our feasibility was positive. Between 3 centers, we recruited 26 patients. And in that 26 patients, we found out the outcome was always positive, but the complications because the electrodes didn't stay was high. So we moved on to the next stage. By this time, the company had raised more money, and they did electrodes to test out. And the electrodes were designed, so as you can see, that's the anchor. This is just the Medtronic Titan anchor, if anybody knows that. And we use Medtronic electrodes and Senjude electrodes to do this system. And we still have patients who successfully use this. For some reason, some of them still seem to stay without falling out. So we then changed the technique and said, right, you can't go too lateral. Let's come a bit more medial. And the more medial you are, you're better. And we then introduced umbrella at the top of the electrode, like a time, to hold it in the muscular fascia. So that was brilliant. But then we anchored the other end. So what we found was electrodes were fracturing because you had 2 fixed ends and the electrodes stretched in between, and we had plenty of electrode fractures. We corrected that, and then we carried on, and then we found out as we went very lateral, it was still going through the muscle plane, so it was fracturing the electrode because of that. So eventually, the final position we came up was to go dead midline and then place the electrodes out without getting into the muscle plane. Procedure takes literally 25 minutes, 30 minutes, so it's not a tedious procedure. It's so easy to stimulate the L2 medial branch. And this is when they moved on to the next stage of doing the FDA study to get it approved by FDA to have it as a routine treatment option. So this study was looking at randomizing 200 patients, but the FDA required that they wanted a sham arm. And there was no choice for them. They said, you've got to do a sham. And we said, hang on a minute, sham for 3 months? That's kind of, it's got to fail because sham will have an effect in the first 3 months. It's only as time goes on, sham fails. But FDA wasn't interested. They just wanted sham arm for 3 months, and that was it. So the study was between active treatment to sham treatment. So they all were implanted, but the sham group had very small amount of electricity, whereas the active group had the proper treatment arm. So they were looking at more than 30% pain reduction in the responders. And as you can see, this again is a young group of patients, about 47 average, with a duration of back pain going anywhere between 14 to 25 years. So this is like a really chronic patients here. Back pain predominantly, just back pain. There's no neuropathic leg pain at all in this group. The disability is less because this is an FDA study, so they're very clear on not having too disabled or less disabled. Again, the pain score has to be not too high, but not too low. So the selection criteria was quite tricky in this study. But they still managed to complete it. And as you can see, the sham had 47 response rate comparing to 57. This is going to kill them. But the FDA recognizes any kind of device-related study that is going to be sham response, but they all cross over at 120 days, and they all maintain the pain relief throughout. The only thing that they did not achieve statistical endpoint is on the remitter rate, and they call it remitter rate if somebody's pain is less than 2.5 on a scale of 10, then they have got remission, and that's something which is kind of quite heavily talked about in neuromodulation work now. And so just to give you the final outcomes, 64% achieved more than 50% pain relief, 75% had more than 30% improvement. And I think, after being a clinician who took part in this study, I could see a significant difference in this group of patients, because I had a patient of mine who's now running 50 miles a week. And that's kind of the response that they are getting. But this is time to see what happens, because this was only presented last week, and they kindly sent me the slides for me to show you guys here. So this is hot off the press, but they're going to FDA soon, and we'll find out whether this becomes a routine treatment. And if so, this would be the first treatment for non-neuropathic mechanical stabilization kind of area. And I always used to tell the company, why are you denervating? We should be modulating facet joints. And there is something that might happen or might not happen. But let's see. So other studies, there's loads. I mean, if you let me, I'll keep talking, and I think we've got to stop soon. I looked at the EEG changes in patients before and after stimulation, and this is comparing two different modalities of stimulation, and that's purely based on the work of burst stimulation having effect on both medial and lateral pathway, and looking at both the emotive component of pain and the pain itself. Minuteman is a study that we're currently doing. We just completed the recruitment, looking at interspinous fusion device for spinal stenosis, and this is in conjunction with our neurosurgeons. I was the chief investigator with 4 or 5 centers. I really struggled to recruit for the study, because our surgeons don't believe in anything interspinous, because they said everything which went in like X-stop and spine jack and things, they always come out after a couple of years, so they're not interested. Whereas our first few patients have already crossed 5 years, and it forms a fusion in between the spinous processes rather than just distracting. So those results are being analyzed as we speak. Panacea is a study where I'm looking at chronic pancreatitis, looking at conservative management versus spinal cord stimulation for chronic pancreatitis. Non-surgical back pain, which we talked about. Reactivate is a muscle reactivation study, which we just completed. We also looked at autonomic nervous system in patients who are undergoing neuromodulation. So the idea is anything that we do has to be a sympathetically mediated pain. So we looked at mononeurography, where we stick a needle into the peroneal nerve, and we measure the nerve activity, and we can calculate the amount of sympathetic activity based on that. And we had some interesting results. We only did a pilot of 12 cases, and we found 2 of them failed the trial, and they both had a really high autonomic tone. So now we're trying to expand the study to actually see if we can change the autonomic tone and then offer them the stimulation, whether that would make a difference. We're looking at peripheral vascular disease, which is not an indication that is currently being approved by the UK. So peripheral vascular disease and angina is not approved in the UK. So that's the cadaver course that I run. Leeds is not too far. There's a 6-hour flight from here. If anybody's interested in coming, you're more than welcome. Our next course is on the 9th and 10th of May, and it's a nice time because it's spring and it slowly gets greener and it's not dimmer and grayer. It still can be, I can't promise. And we wrote a handbook for the spinal intervention, which goes as a course material with our course. And I'm the current president of the Neuromodulation Society of UK and Ireland. Our next ASM is in Leeds again on the 15th to 17th of November, which is a Saturday and Sunday. So if anybody wants to see what's happening in the world of neuromodulation, you're more than welcome. And if you let me know, you can come and stay with me. Right, thank you guys. Any questions? Apologies for the people who I gave you a bit of wave
Thanks very much, Barney. Are there any questions online? No? Okay, great. Questions for Barney?
Nope, they're all waiting to go. Yeah.
Vlad.
So we're currently deliberating a few topics regarding this bill. And you said that in the UK, there's no funding for epidural injections at all?
No, it is very restricted. In essence, you've got to satisfy the criteria. The criteria is if you have an acute sciatica, then you can have an epidural or a transforaminal epidural. That's completely acceptable. But you can't keep repeating that every 3 months. We used to do epidurals for spinal stenosis. Now that's completely stopped. They said there's no evidence. We used to argue with them to say, look, these are all patients who are not fit to have surgery, but the government is not interested. They just said, no, you're not doing them anymore. And
what about, I'm sorry, go ahead.
When it comes to back pain, we are allowed to do medial branch block followed by radiofrequency. And those are the only interventions in spine. And again, you can do the same in the neck.
So what about image guidance with epidural?
We don't do anything without image guidance. We never do anything without image guidance. Because especially the patients coming with pain, the last thing you want to do is blind. So every single intervention we do is with either ultrasound guided or X-ray guided. In our hospitals, 100% X-ray guided.
What about contrast for medial branch blocks and for epidural injections?
For epidurals, yes, we don't use contrast for medial branch blocks. And the reason behind is the moment you put the contrast, if you're not through the malleoaxillary ligament, you get a blobogram and it becomes difficult after that to see the difference. As long as you get an inferior oblique view, you can see where your needle is perfectly.
Art.
So, interesting. Thank you very much. In terms of trial to success, final, what's your visualization?
We looked at our trial to success rate. Our trial to success rate is about 90% straight away, right at the beginning. And then over a 6-month period, there's about 14% drop. I mean, that's the graph which, because of the technology, has gone. And I think all the animation has been taken out once it has been telecasted, I think. So we have 14%, sorry, not 14%. Our trial success rate is approximately 90%. And at 20 weeks, at about 6 months, there's about 1 to 2 patients fail out of that. So in essence, the total success rate is approximately 80%. So we don't do trials anymore because we did a study looking at trial, no trial. Between 3 centers, we've randomized 100 patients. The idea is we have a group of patients where they had a routine trial followed by full implantation, and another group where they went directly for implantation. We did the health economic data on the cost analysis, and we came to a conclusion that if somebody has a non-rechargeable system, which is a primary cell, you need 70% success rate to go directly for full implant. If you have a rechargeable system, which costs a bit more, you need 80% success rate. And if your service is more than 80%, then you might as well do a full implant rather than doing the trial. And we also looked at the patient satisfaction out of it, because if you look at the patient side of things, they have to take time off for trial, which would be 2 weeks, and then they have to take time off for full implant, which is 4 weeks, and they have to wait in between because of the waiting time I've showed you. Some of the patients have been trialed last year, and we implant them the following year, and that's a long time to wait to say, right, you can be like this, but you got to wait for another 6 months, 8 months. So we moved on to doing all implants straight. But these are patients who are straightforward. So you want to have a correct indication, realistic expectations from the patient, not on huge amount of opioids, then they go through this pathway. If they have high expectations, psychologically needed a lot of work to do before we get in, opioids we've reduced, but they're not really reduced to the level we want, and if there's any doubt, we tend to still trial them.
So, because at least for our patient group, it's a big advantage when we talk to them and say, you know what, because the biggest thing is fear, because not just sticking a needle, but it's going to be with them permanently. And telling them that, you know, the biggest thing is you have a trial and you'll be fully convinced to go to the final implant, make them more appealing for that. So I think,
I mean, it is purely introduced in a system like here, it might work better because you're remunerated differently to what we do in the UK. And for us, there is no advantage as a clinician to do it in 2 sittings. There is no advantage as a patient who is well selected to come twice. And there's no advantage for an NHS as a healthcare to pay twice for something that we have shown clear cost effectiveness by going directly. And now we've done the study to prove that. So that results are coming out in May. And once that comes, NHS will change it to say, good patient selection, implant direct, don't do a trial.
Sorry, another question. So, how long is the follow-up going to be? Because I think one of the biggest challenges for neuromodulation in general is most patients are at least 5 years is the mark where you tend to see some negative trend with patients. Some improve, just change the whole life, but there is always patients who fail.
I mean, you got to understand, neuromodulation is not a therapy for lifetime. Anything we do in pain medicine is to give them that little holiday so they can work on their rehabilitation and move on. So when you're doing a facet joint injection, it's not like you do an injection and then they get better and they come back again 6 months and they keep coming back. Whereas the key in managing this patient is that rehabilitation that you put in. And neuromodulation is just the same. When you do it, yes, you're controlling the pain, but you've got to work with them on rehabilitating. And that's key. Yes, on the longer term, there is tolerance comes with it. There's all other things comes with it. So you have to put that programs in place for you to be able to try and maintain that amount of pain relief that you have. We have introduced in the neuromodulation database that there's going to be a yearly follow-up because it's electronic follow-up, so we should have a lot more data as time goes on. Locally in the hospital, we try to see the patients on a yearly basis, and the data that I'm currently collecting of approximately 450, and that is going to be probably 600 by next year this time, is over the whole period that they've been with us. So some of the data that I presented is the patients have had the implant more than 5 years. The ones who don't do well, you can't do anything about it. And that you'd know within 6 months. No. Because it's not funded to start with. And when I first started, we used to do them. And we audited it, and we didn't find a huge difference to the patient's outcome. They were quite dependent on it because they just say, right, I'm ready for my infusion. So you send them for 6 weeks, they'll come and say, oh yeah, last week my pain started. You send them for 8 weeks, they say, yeah, last week my pain started. So there's no difference. And some of them even come after 3 months, and it's always, I was well until last week and it just started. And it was very evident that we don't do them anymore.
So clearly the key is to schedule them annually.
Yeah. And the other thing we used to do is some of these patients where you do a steroid-based SI joint injection or a facet joint. I mean, I don't know how many of you use steroids for your facet joints. Right. I mean, we don't use any steroids on these injections because if you give steroids, you're still giving. It's equivalent to giving an IM steroid. So one of the things that we did was when we did SI joint injections, people used to get an SI joint diagnostic cum therapeutic, so they put a bit of steroids in. Patient come and say, oh, I was great for 3 months in the clinic. So we just give them an IM depomedron and they're great for 3 months. So we just say it's not the injection, it's the steroid. And it's just, it makes them move on. And the key is not to keep them within the service. We try our best to try and give them a pathway out. And some of them want to keep coming back in. You can't do anything about them. But majority, with a change in the healthcare system, we managed to do that. And also, I'd rather see patients where I can make a difference than see the same patients and keep repeating the same thing.
Barney, thanks very much. I have to admit, it's always, as an educator, when you offer programs, it's considered a success when the student is more competent and more accomplished than the teachers. So it's good to see you again. Thanks very much for coming. Thanks everybody for your attendance. The number that was on the very first slide,
I'll give you that again.
Is the number that you need to use to submit for the CE accreditation if you need the attendance certificate. Anyway, great. Thanks very much.
Yeah.